Welcome to Pediatric Case Review. Today we present a comprehensive case-based review of methylmalonic acidemia for general pediatricians. This is one of the most important organic acidemias you will encounter in clinical practice. We will walk through 12 carefully crafted clinical cases covering neonatal presentation, pathophysiology, differential diagnosis, diagnostic workup, vitamin B12 responsiveness, acute emergency management, chronic dietary management, long-term complications, and neurological monitoring. Let us begin. Case 1. A 3-day-old term male infant is brought to the emergency department with poor feeding, progressive lethargy, and recurrent vomiting since birth. He appears hypotonic and poorly responsive. Labs show a pH of 7.18, bicarbonate of 8 millimoles per liter, ammonia of 350 micromoles per liter, and normal blood glucose. What is the most appropriate immediate next step in management? Option A. Administer broad-spectrum intravenous antibiotics for suspected neonatal sepsis. Option B. Order plasma amino acids and urinary organic acids immediately. Option C. Start intravenous fluid resuscitation with high-concentration glucose infusion. Option D. Prepare immediately for extracorporeal ammonia detoxification. The correct answer is Option C. Intravenous fluid resuscitation with glucose infusion. In a critically ill neonate with suspected organic acidemia, the first priority is stabilization, not diagnosis. High glucose infusion reverses dehydration, restores circulating volume, and most importantly halts catabolism of amino acids and fats. This reduces the production of toxic propionyl coenzyme A and methylmalonic coenzyme. Remember, catabolism is the enemy and glucose is the first weapon. Antibiotics and metabolic workup absolutely follow, but stabilization always comes first. Case 2. A 9-year-old girl presents with a 2-year history of increasing fatigue, difficulty concentrating at school, and occasional nightmares. Her family recently adopted a predominantly vegetarian diet. Examination reveals pallor and decreased lower limb muscle tone. Labs show hemoglobin 84 grams per liter, mean corpuscular volume 128.7 femtoliters, homocysteine 159 micromoles per liter, and both serum vitamin B12 and folate are normal. What is the most likely underlying diagnosis? Option A. Iron deficiency anemia. Option B. Folic acid deficiency. Option C. Combined methylmalonic acidemia with homocystinuria, cobalamin C type. Option D. Hypothyroidism. The correct answer is Option C. Combined methylmalonic acidemia with homocystinuria, cobalamin C type. The cobalamin C defect impairs intracellular cobalamin processing, affecting both adenosylcobalamin and methylcobalamin. This results in both elevated methylmalonic acid and elevated homocysteine simultaneously. Critically, serum vitamin B12 appears normal because the defect is intracellular, not dietary. The vegetarian diet unmasked or worsened the phenotype. The classic triad is macrocytic anemia, elevated homocysteine, and neurological signs. The gene involved is called MMACHC. Case 3. A 6-month-old male infant presents with recurrent vomiting, lethargy, and poor feeding. Labs reveal severe metabolic acidosis with an elevated anion gap. Newborn screening follow-up shows markedly elevated propionyl carnitine, also known as C3. Plasma ammonia is normal. The infant is hemodynamically stable. Which finding on urinary organic acid analysis is most consistent with this presentation? Option A. Markedly elevated methylmalonic acid and methylcitrate. Option B. Elevated orotic acid and citrulline. Option C. Elevated isovalerol glycine and 3-hydroxyisovaleric acid. Option D. Elevated 3-methylcrotonol glycine and 3-hydroxyisovaleric acid. The correct answer is Option A. Markedly elevated methylmalonic acid with mildly elevated methylcitrate. Urinary methylmalonic acid detected by gas chromatography mass spectrometry is the hallmark finding of methylmalonic acidemia. Methylcitrate is elevated in both methylmalonic acidemia and propionic acidemia, so it is not specific alone. The key distinction is that methylcitrate without elevated methylmalonic acid suggests propionic acidemia instead. Gas chromatography mass spectrometry urinary organic acid analysis is the gold standard test for confirming organic acidemias and differentiating between these two conditions. Case 4. A 10-day-old male infant is admitted with severe metabolic acidosis at a pH of 7.10, hyperammonemia with ammonia at 410 micromoles per liter, and markedly elevated urinary methylmalonic acid on gas chromatography mass spectrometry. Newborn screening flagged a significantly elevated propionyl carnitine level. Genetic testing later confirms an isolated form of methylmalonic acidemia with no elevation in plasma homocysteine. Which enzyme or cofactor defect is the primary cause of isolated methylmalonic acidemia in this infant? Option A. Propionyl coenzyme A carboxylase deficiency. Option B. Methylmalonyl coenzyme A mutase deficiency or its adenosylcobalamin cofactor defect. Option C. Biotinidase deficiency impairing multiple carboxylases. Option D. Defective intracellular cobalamin metabolism causing combined methylmalonic acidemia and homocystinuria. The correct answer is option B. Methylmalonyl coenzyme A mutase deficiency. The enzyme known as methylmalonyl coenzyme A mutase converts methylmalonyl coenzyme A to succinyl coenzyme A in the tricarboxylic acid cycle. It requires 5'-deoxyaminosilcobalamin, a vitamin B12 derivative, as its essential cofactor. Deficiency leads to toxic accumulation of methylmalonic acid and propionic acid. This disrupts energy production, the urea cycle, and mitochondrial function. An important clinical pearl is that vitamin B12 responsive subtypes such as cobalamin A and cobalamin B retain partial enzyme function, so always test for vitamin B12 responsiveness. Case 5. A 7-year-old boy with known mutant 0 methylmalonic acidemia presents for routine follow-up. Despite strict dietary control, his metabolic team notes persistently elevated urinary methylmalonic acid levels and worsening mitochondrial dysfunction on muscle biopsy. His sirtuin 5 enzyme levels are reported as significantly reduced. Which of the following best explains how accumulated methylmalonyl coenzyme A contributes to ongoing mitochondrial damage beyond the primary enzyme block? Option A. Direct inhibition of the electron transport chain complex 1 by methylmalonic acid. Option B. Non-enzymatic methylmalonylation of lysine residues on mitochondrial proteins, impairing their function. Option C. Competitive inhibition of succinyl coenzyme A synthetase, halting adenosine triphosphate synthesis. Option D. Upregulation of sirtuin 5 deacylase activity, causing excessive protein deacetylation. The correct answer is option B. Non-enzymatic methylmalonylation of lysine residues on mitochondrial proteins. This is a newly recognized mechanism in methylmalonic acidemia pathophysiology. Accumulated methylmalonyl coenzyme A non-enzymatically modifies lysine residues on mitochondrial proteins through a process called protein methylmalonylation. Sirtuin 5, a mitochondrial sirtuin enzyme, normally removes these modifications, but its activity is impaired in methylmalonic acidemia. The result is hyperacylation leading to tricarboxylic acid cycle dysfunction, urea cycle disruption causing hyperammonemia, and energy failure. This is recognized as a post-translational modification and a newly understood driver of disease pathophysiology. Case 6. A 6-day-old male neonate is referred after newborn screening flagged an abnormal metabolite profile. He has been feeding poorly since day 3 of life and is now lethargic with mild hypotonia. Blood gas shows metabolic acidosis with a pH of 7.21 and bicarbonate of 10 millimoles per liter. Plasma ammonia is 185 micromoles per liter. Which of the following findings on tandem mass spectrometry of plasma acylcarnitines is most characteristic of methylmalonic acidemia? Option A. Elevated free carnitine, called C0, with normal C3. Option B. Elevated isovalerial-carnitine, called C5, with low C0. Option C. Markedly elevated propionyl carnitine, called C3, with increased C3 to C2 ratio. Option D. Elevated octanoyl carnitine, called C8, with normal C3. The correct answer is option C. Markedly elevated propionyl carnitine with an increased C3 to C2 ratio on tandem mass spectrometry. Propionyl carnitine above 5 micromoles per liter is a key screening marker for both methylmalonic acidemia and propionic acidemia. A C3 to C2 ratio greater than 0.25 is highly suggestive. The elevated C3 reflects upstream accumulation of propionyl coenzyme A. Tandem mass spectrometry is the backbone of newborn screening programs worldwide. However, you must always confirm with urinary organic acids to distinguish methylmalonic acidemia from propionic acidemia. Case 7. A 6-week-old male infant was referred after newborn screening flagged an elevated propionyl carnitine level. Follow-up urinary organic acid analysis confirmed markedly elevated methylmalonic acid. Plasma acylcarnitine ratio of C3 to C2 is 0.42. He is currently clinically stable on dietary restriction. His metabolic team suspects isolated methylmalonic acidemia, but needs to identify the precise genetic subtype to guide prognosis and vitamin B12 trial planning. Which investigation is the most appropriate definitive method to confirm the specific subtype in this infant? Option A. Repeat plasma acylcarnitine profile with C3 to C2 ratio trending. Option B. Liver biopsy for methylmalonyl coenzyme A mutase enzyme activity assay. Option C. Urine methylmalonic acid quantification by gas chromatography mass spectrometry. Option D. Molecular genetic testing of the genes including MUT, MMA, MMAB, MMEDHC, or MMECHC. The correct answer is option D, molecular genetic testing. Molecular genetic testing confirms pathogenic variants in the genes MUT, MMA, MMAB, and MMECHC. It is essential for definitive diagnosis after biochemical suspicion is established. The diagnostic pathway starts with clinical suspicion based on metabolic acidosis, hyperammonemia, and elevated C3. Biochemical screening with plasma acylcarnitines and urinary organic acids follows. Then biochemical confirmation with gas chromatography mass spectrometry and plasma amino acids narrows the diagnosis. Finally, molecular genetic testing through gene panel or whole exome sequencing provides the definitive answer. This guides genetic counseling and prenatal diagnosis for future pregnancies. Case 8. A 14-month-old boy with known methylmalonic acidemia presents for routine follow-up. Genetic testing confirmed a pathogenic variant in the MMA gene. His metabolic team is considering initiating vitamin B12 supplementation as part of his long-term management. Which genetic subtype of methylmalonic acidemia typically demonstrates the most significant and consistent clinical response to vitamin B12, specifically hydroxycobalamin, supplementation? Option A. Mutant 0, which is a complete enzyme absence from the MUT gene. Option B. Mutant minus, which has partial residual activity from the MUT gene. Option C. Cobalamin A, which is an MMA gene defect. Option D. Cobalamin B, which is an MMAB gene defect. The correct answer is option C, cobalamin A, which is an MMA gene mutation with the highest vitamin B12 responsiveness. Both cobalamin A and cobalamin C subtypes show excellent vitamin B12 response, making hydroxycobalamin supplementation a cornerstone of their treatment. The mutant minus and cobalamin B subtypes show partial or variable response, so a trial is warranted. The mutant 0 subtype has no response because vitamin B12 provides no benefit when the enzyme is completely absent. A critical take-home point is that every newly diagnosed methylmalonic acidemia patient should be systematically tested for vitamin B12 responsiveness. Hydroxycobalamin is preferred over cyanocobalamin. Case 9. A 14-month-old boy with known methylmalonic acidemia, mutant 0 subtype, is brought to the emergency room with 12 hours of vomiting and lethargy. He is irritable, hypotonic, and poorly responsive. Ammonia is 480 micromoles per liter. Blood glucose is 52 milligrams per deciliter. What is the single most important immediate intervention? Option A. Administer intramuscular hydroxycobalamin and observe. Option B. Start broad-spectrum intravenous antibiotics for suspected sepsis. Option C. Stop all protein intake and initiate intravenous glucose infusion. Option D. Perform immediate liver biopsy for enzyme confirmation. The correct answer is option C. Stop all protein intake and initiate intravenous glucose infusion. This is a metabolic emergency requiring action within minutes. The immediate steps in the first 30 minutes include stopping all protein intake to halt propionate production, establishing intravenous access, drawing labs for ammonia, blood gases, glucose, and amino acids, starting 10% dextrose at a high infusion rate, and keeping the patient nil per OS with no enteral feeds. For a known methylmalonic acidemia patient, also give intravenous hydroxycobalamin as a single megadose, L-carnitine at 100 mg per kilogram intravenously, and continue high-rate dextrose. Ammonia scavengers including sodium benzoate and sodium phenylacetate are given at 250 mg per kilogram as a loading dose. If ammonia remains above 300 micromoles per liter after 4 to 6 hours, consider extracorporeal detoxification with continuous renal replacement therapy or hemodialysis. Case 10. A 4-year-old boy with confirmed mutant 0 methylmalonic acidemia is stable on a low-protein diet. His plasma-free carnitine level is significantly low. His metabolic team plans to initiate L-carnitine supplementation. What is the primary biochemical mechanism by which L-carnitine supplementation benefits patients with methylmalonic acidemia? Option A. It directly activates the methylmalonyl coenzyme, a mutase enzyme, restoring normal metabolism. Option B. It enhances renal tubular reabsorption of methylmalonic acid, reducing urinary losses. Option C. It conjugates toxic propional coenzyme A to form propionyl carnitine, enabling urinary excretion of the toxic load. Option D. It stimulates hepatic gluconeogenesis to prevent hypoglycemia during metabolic stress. The correct answer is option C. L-carnitine facilitates excretion of propionyl groups via urine. Here's how it works. Propionyl coenzyme A accumulates in methylmalonic acidemia and is toxic to mitochondria. L-carnitine binds propionyl coenzyme A through the enzyme carnitine acyltransferase to form propionyl carnitine. Propionyl carnitine is water-soluble and is safely excreted in urine. Additionally, coenzyme A is regenerated in this process, which restores mitochondrial function. The typical dose is 100 to 300 mg per kilogram per day, given orally or intravenously. L-carnitine also corrects the secondary carnitine depletion that is very common in methylmalonic acidemia patients. Case 11. A 14-year-old male with confirmed isolated methylmalonic acidemia, mutant 0 subtype, has been followed since the neonatal period. Despite reasonable dietary compliance and L-carnitine therapy, his last 2 annual reviews show rising serum creatinine and persistently elevated plasma methylmalonic acid levels. His blood pressure is 118 over 76 millimeters of mercury. Urinalysis reveals mild proteinuria. Glomerular filtration rate estimated by cystatin C is 52 milliliters per minute per 1.73 meters squared. Which of the following represents the most common progressive long-term organ complication in patients with isolated methylmalonic acidemia? Option A. Dilated cardiomyopathy. Option B. Progressive chronic kidney disease. Option C. Optic nerve atrophy. Option D. Hepatic cirrhosis. The correct answer is option B. Progressive chronic kidney disease. This is the most common long-term organ complication in isolated methylmalonic acidemia. The hallmark pathology is chronic tubulointerstitial nephritis with tubular atrophy, interstitial fibrosis, mononuclear infiltration, and mitochondrial dysfunction in proximal tubules. The pathogenesis involves proximal tubular mitochondrial dysfunction combined with elevated serum methylmalonic acid causing direct tubular injury. An important clinical point is to use cystatin C rather than creatinine for estimating glomerular filtration rate, because creatinine overestimates kidney function due to the low muscle mass common in these patients. Renal function should be monitored every 6 to 12 months with plasma methylmalonic acid levels as an additional marker. Case 12. An 8-year-old boy with known isolated methylmalonic acidemia, mutant 0 type, presents to the neurology clinic for routine follow-up. He recently recovered from a febrile illness during which he had transient right-sided weakness and slurred speech lasting 48 hours. He has a history of 2 prior metabolic decompensation episodes. His parents report increased clumsiness and a new involuntary writhing movement of his left hand over the past month. A brain magnetic resonance imaging is obtained. Which of the following magnetic resonance imaging findings is most characteristic of methylmalonic acidemia-associated neurological injury in this patient? Option A. Diffuse cortical atrophy with bilateral temporal lobe signal changes. Option B. Symmetric T2 hyperintensity of the bilateral globus pallidus with restricted diffusion. Option C. Periventricular white matter lesions consistent with demyelinating disease. Option D. Unilateral caudate nucleus hemorrhage with surrounding edema. The correct answer is option B. Symmetric T2 hyperintensity of the bilateral globus pallidus with restricted diffusion. This is the hallmark neuroimaging finding in methylmalonic acidemia. It occurs during acute metabolic decompensation episodes. The globus pallidus is selectively vulnerable due to mitochondrial energy failure. These lesions are associated with movement disorders, including dyskinesia and chorioathetosis. Lesions may partially resolve with metabolic stabilization. An important point is that brain magnetic resonance imaging should be recommended after every decompensation episode. A helpful clinical pearl is that methylmalonic acidemia typically causes pallidal lesions, while propionic acidemia tends to affect the basal ganglia and white matter. So the magnetic resonance imaging pattern helps distinguish between the two conditions. Before we wrap up, we want to share something special with you. If you are enjoying these case-based lectures and want to take your learning to the next level, consider joining our Patreon community called Pediatric Case Review. Inside the community, all videos are meticulously arranged by body system, so you can access every lecture in one organized place. Plus, all presentation slides are available as downloadable images, so you can review and practice all questions anytime, anywhere. For details on how to subscribe, simply comment below this post, and we will message you directly. Here is a summary of the key takeaways and clinical pearls from today's lecture on methylmalonic acidemia. Red flags include unexplained vomiting in a neonate, lethargy and hypotonia, metabolic acidosis with a high anion gap, and hyperammonemia. Diagnostic clues include elevated urinary methylmalonic acid, high plasma C3 to C2 ratio, macrocytic anemia with high homocysteine, and gas chromatography mass spectrometry urine organic acids. Treatment pillars include a low-protein diet with amino acid formula, L-carnitine supplementation, hydroxycobalamin if the patient is vitamin B12 responsive, and oral metronidazole to reduce gut flora. Major complications include chronic kidney disease, metabolic stroke affecting the basal ganglia, optic atrophy, which is rare, and neurodevelopmental delay. Thank you for watching this lecture on methylmalonic acidemia. We hope you found it informative and clinically useful. Remember, these lectures are for educational purposes only and do not constitute medical advice. Always consult current clinical guidelines and relevant specialists for individual patient care decisions. Please follow the Pediatric Case Review channel for more in-depth clinical lectures on pediatric topics. If you have any questions or topics you would like us to cover, please comment below. Keep learning, keep growing, and together we can provide better care for every child.